So we are live. This is Dr. Abbasi for Essence in our clinical case review. Today we are going to talk about the spinal deformities. And I have prepared, or my team has prepared, whether to say a presentation for us with some videos. I'm sorry, with some pictures. So I'm going to open up this presentation now. Okay. I'm hoping that everybody can see that now. Today, we are going to talk about scoliosis or spinal deformity. Now, if you look at the spine, and I'm going to try to get a picture of that here. If you look at the spine from this side, we have some natural curvature. And we call that in the cervical area, we call it lordosis. In the chest area, we call it kyphosis. And in the lower back, we call it lumbar lordosis again. But if you look at the spine from the front, it should stay straight and should go straight up without any curvature. Now, obviously, the curvature in the side view can be exaggerated or less, and that we call that so-called sagittal deformity. But today I would like more talking about the side bending abnormality of the spine, the so-called spinal scoliosis. And one of the hallmark of this spinal scoliosis is that it becomes unphysiologic for spine and muscle in the spine to work. Obviously, there are some horrendous kind of scoliosis where it to a point that we cannot even use our chest and the ribs for a breathing process. That can become really difficult if it becomes unsustainable. Now, certainly in medicine, we use the Latin words like levoscoliosis for the scoliosis that turns to the left, and dextroscoliosis for scoliosis that turns to the right. And by the way, I think actually the convexity is called. So if this is a front view, that would be actually dextro. This one would be levoscoliosis. But nevertheless, we identify how much our spine is side bending based on an angle. In the front view, if you remember, that angle should be 0. So if that angle is not 0, that's not normal. As well, we have a name for that angle. We call that angle Cobb angle. Hello? Yeah, that is okay for now. Okay, we can give him, yeah, that is okay for now. He got his the bracing inside, the hardware that I put in. The brace, outside brace is just for comfort. He should still ambulate with that flimsy brace, please. Yes, please. Thank you. Bye-bye. Okay, taking care of the patient and doing podcast. So let's look at that. That's actually a patient I did a scoliosis surgery just today. So let's talk about this. Now you see here that we have 7 vertebrae in our neck, 12 in our chest, and then 5, usually 5 in our lower back. And any side bending in the lower in the spine is called scoliosis. Most of the time, the side bending is more pronounced in an adult in the lower back, whereas in many children, where the side bending is mostly in the thoracic spine, in the chest spine. These are 2 categorically different kind of scoliosis which we call juvenile or pediatric scoliosis versus adult degenerative scoliosis. The adult degenerative scoliosis is mostly in the lumbar spine, in the lower back, because the discs that are separating the bone, they are collapsed unequally, and practically that makes the bone tilt to one side or another. Let's look at the correction here. Here's one of my patients, let's go back. And why is it important? Because in the different kind of tenet apply to juvenile versus adult scoliosis. A child is going to live 50, 60, 70 years with this. So there are way more consideration. We have to make sure that certain situation is optimized for a long haul, whereas, and as well, in this kind of cases, we do these really big surgeries to correct the situation for a long haul. Whereas in the adult, first of all, the life expectancy is not as long as a child, but as well, that the mechanic is extremely different than a juvenile scoliosis. One of the big mistakes that is being done right now is that many, especially young spine surgeons, they apply the tenet of the juvenile scoliosis correction to adult, and literally they want to go and correct the 70-year-old spine to a 25 or 20-year-old spine by overcorrecting. Actually, sometimes they cause more damage, but as well, a surgery that could be done in a limited fashion, either they overdo it, instead of doing a segmental correction, they do a horrendous surgeries that are T5 to S1, or on the opposite side as well, lots of people who would benefit from a segmental correction, they don't get it because in the mind of some younger surgeon, you have to do it all or none at all. These patients are told they have to go and live with the pain, and many of them truly they don't. It's not unusual for lots of people to commit suicide because of the pain in their spine. Spinal pain is one of the worst pains anybody can have. Here you see like a segmental correction. Patients still have the scoliosis above the level we fixed, but this patient is functional. This is an elderly that the regular correction from T5 to S1 would be unsustainable. This is too much surgery, but we do a surgery like that usually in 1.5 to 2 hours with a minimal blood loss, and that can correct patient clinical symptoms. The picture may not look good, but again, unfortunately, there are two camps in the spine, correcting the picture versus correcting the patient's problem. Here you see spacers, and these spacers are put to separate the bone. And you see the screws that on each side are connected together with a rod. You see that, especially in this patient, the screws are placed in a very strategic location, and some of the screws are skipped, as you see here. The L5 screw here and L4 screw on this side is skipped. Sometimes the angle is just not sustainable. This is the same patient before the surgery. And then you see that all of a sudden, in the area of the surgery, most of the side bending is corrected. Obviously, above it, it's still not corrected. But again, sometimes we have to choose if you want to correct the patient's symptoms or the pictures. Here, you see the pelvis, you see the sacroiliac joint, you see the ala of the sacrum, L5, L4, L3, L2, L1. If you look carefully, here is the pedicle and here is the pedicle. The spinal process here is equidistance, meaning this is a true AP picture for this vertebral body. But if you look carefully, the spinal process is all the way here because this vertebral body are not only turned to the side, but they are rotated. We call that torsional abnormality. And that is extremely important. Additional thing that you see is there are the ribs. You see the air in the colon, air in the small intestine. And honestly, I don't know even what that is. It's almost look like some metallic object outside of the body. Now let's look at this picture. Here, is another X-ray that you see a hugely distended big intestine, large intestine. That would be called ileus. Unfortunately, lots of patients after surgery, because of the narcotic, the bowel mobility goes down, and they can practically create a situation that the peristaltic goes down, and the gases and the fluid inside of the intestine, they practically don't get passed on. And here you see a large intestine that is extremely large. This is almost at the danger of rupturing. And we call that ileus, that situation. Again, you see the iliac crest, sacroiliac joint, ala of the sacrum. Ala means the wing in Latin, L5, L4. And again, you see the same thing, the side shifting of the spinal process, which indicate that the vertebral body is rotating. This is another patient after the surgery that you see here that the scoliosis is completely gone and the bone is growing. You see the spacers, you see the screws, and here the same patient before the surgery where you see the air accumulation inside and the side bending of the spine. The air, what we call air or vacuum effect inside of the vertebral body, is practically a mechanically decomposing nitrogen, the mechanically decomposing disc. The material of the disc, including cartilage, has protein. That protein have amino acid have nitrogen. That's what make amino acids. And that air that is, or nitrogen that is from the decomposition of the protein accumulate inside of the disc, and that is why you see it dark. Otherwise, you see dark in the lung. That's a regular air coming from outside, but this air is obviously not coming from outside. Anywhere else beside the joint, if you see this, it's a dangerous thing because that means there is a bacterial infection going on. As well, you see the edge of the bone is thicker. We call that hyperostosis. That is because literally the bone is hitting the bone. A disc is like a tire of a car, and I compare that to my patient like you have a flat tire and now you're driving on the rim and the rim has changed. Here you see so-called the sagittal and coronal view in the CT of the lumbar spine. And you see again, bone is growing. And one of the things that the younger surgeon or in the medical field mistake that we do is that we look at one film and we decide that something is in the wrong place or in the right place. You have to look at many, many different pictures to come to the conclusion. And this is yet another patient that you see the scoliosis. This is the so-called adult degenerative scoliosis, very different than pediatric scoliosis. So never try to apply the same tenet of the juvenile scoliosis to adult scoliosis. This is the same patient after the surgery, and as you see, most of the scoliosis is corrected. Here you see the hip joint, femur, and here artificial hip. This is a spinal cord stimulation device. This is what you see here, a stool in the rectum. Here you see the screws, and lung, you see the vascularization of the lung. And let's go to the next slide. Here you see the X-ray versus this picture is what CT machine produces before it takes the actual CT, but this is a regular X-ray. You see the quality is very different because this is a digital picture. This is an analog picture. But in both of them, you see air in different compartments in our intestines, a femur, pelvis, iliac crest, and again, here you see the rotational and side bending of the spine. So I like actually to come to a conclusion here. This is a bigger surgery. This is a 5-level fusion. This by itself would be an unimaginable long and bloody surgery traditional way. 5 interbody. When we put the interbody in a regular way, We have to cut the bone, we have to cut the facet, we have to deal with epidural veins, and that is where most of the bleeding comes from. In the olive technique, practically we go at the oblique angle, we bypass cutting the bone, cutting the facet, or dealing with the epidural vein. For that reason, we could do this surgery under 2 hours and patient goes home next day. This would be unimaginable for regular surgery. You see a 5-level fusion, L1 to S1, with cages strategically placed to correct the scoliosis. 5 discs are surrounded by 6 bone. Each bone get 2 screws, so 12 screws and 2 rods, 1 on each side. That's what you see. So I'm going to keep it short here and call it a day. But thank you for joining us. This is Dr. Abbasi for Essence of Medicine Case Review. Please join us tomorrow. We have our Inspired Spine Case Review, where lots of experts from around the world joining us to discuss actual cases. Go to our webpage and look for Amanda's email and email us if you wish to get a link. So I'm going to say goodbye. Thank you for watching this, and until next clinical case review,